Okay, well, welcome to the second session of the Geriatric Health Literacy Active Learning Series, sponsored and created and brought to you live by the UTMB East Texas Geriatric Education Center, which is in partnership with the East Texas AHEC. The ETGC is funded by HRSA, and we're in our second year of developing programs that are targeting for geriatric education for health professionals and students in health professions. Many of you have been to our programs before and you're pretty familiar with what we do. And for this session, we have a great agenda set up. Last month, we had our introduction to health literacy. And as a broad overview, the next few lectures we're going to take that broad overview and get really specific on topics that are components of health literacy. So hopefully what we did last month gave you an idea of what health literacy was all about and how it applies to an older population. We have those recorded from last month, and if you would like to take a look at that DVD, we have copies of everything that was recorded for the last session. So, and you're welcome to use those. Either let me know or Beth Schilling, and we'll get you a copy to take a look at. So we have three topics for today. We have Gretchen Roland Rodriguez, who's a social worker over in Baylor University in Waco. She's going to be talking about communication skills in geriatric health literacy, followed by our own Reverend Helen Appleberg, who'll be talking about the role of spirituality in enhancing geriatric health literacy. We'll have a short break while we set up, probably down that corner area, a panel discussion on experience in healthcare, and the panel will include volunteers from our Friends of the ACE unit. So it's a nice variety of information and topics, and I think it's going to be really interesting to hear these different perspectives and how that all fits in to this concept of health literacy. There is a change in the session, in this whole program schedule. Next month we have something scheduled for March 18th, but it is basically spring break for a couple of sites. So it wouldn't be good to do that. So we've changed the schedule to move that March 18th lecture to June. All right? And you should have handouts on all of this, all these slides here. Okay, so you have copies of everything that you'll need. All right, so that's one little change, but everything else looks like it's ready to go for the rest of the months of the program. As always, we teleconference to various sites as part of our service area for the ETGC. We are going to, and I'll show you them again. Ta-da! Baylor University here in Waco, and that's Gretchen, who's going to be speaking. And it's going to be really interesting where we're going to be on the receiving end here at UTMB while she's giving her presentation. And so you won't have to be looking at her screen here to see her slides. I'm going to be running the slides from here and doing it in sync with what she's presenting in Baylor. It's called magic. So we're not broadcasting, it seems, to Ocean View in Texas City today. I don't know where they are, if they were able to get online as well. So, okay. As always, we are also offering free continuing education credits. We have CME credits, and this session is accredited for 3 hours of CME for MDs, DOs, nurse practitioners, and physician assistants. Just to let you know, with the CME, it is considered this whole 5-session series is one activity. So all the CME credits that you apply for will be added up, and you'll get a certificate after now the June lecture. So we'll total them up. Okay. The main things you need to do to get your CME is to fill out the evaluation forms and sign-in sheets. Okay? Make sure you sign in and fill out for each speaker that you are here for, and then give that back to me. Okay. For the other sites, just contact your facilitator at each of the sites and she'll help you. They'll help you with the paperwork. If you have any questions, you could take a look at the CME contact office. There. We are also offering continuing nursing education credits for RNs. LVNs will send you a certificate if needed. And it's the same type of thing that you'll be needing to do. There is a separate packet for CNEs credits, and this is accredited and approved for 3.2 contact hours. There's a credit request form to fill out and get back to me, as well as an evaluation form in that packet. Many of you are familiar with it and you've done it before. And it's nice to be able to offer this because sometimes they're hard to find. We're also offering 0.3 CEUs for social workers, and that is also part of the packet that we're using for CME. All right, the CE attendance form, these evaluations for social workers need to be filled out and given back to me. And again, make sure you sign in using the sign-in sheets that are out on the table. Okay. We're also offering CEUs for physical therapists and occupational therapists. And the main thing is to complete the main evaluation form that's also found on the table. Are there any questions for your CE credits? Everybody knows. Okay, great. Let's see. I need to let you know that none of our speakers today have any commercial affiliations to disclose. I'd like to call your attention also to our GEC website. Something I want to bring your attention to is a program that we did a couple years ago in basic geriatrics and gerontology. It is mighty slow. Hey, there you go. We did this as part of a Scholars of Aging program. And in here are numerous topics in aging, very general, but very good information that's still relatively current, even if it's a couple years old. And you could go through each one of these and take a look at the objectives. You can go, if you have them on Real Player, you could take a look at the videos that were recorded for each of the speakers. We have modules available for each program that you can take a look at, and there are 12 of them. And I encourage, if you have some time, take a look. I think it's good information. All right, enough of that. Okay. On with the program. I'd like to introduce our first speaker, Gretchen Rodriguez. She's Associate Director of the Center for Literacy at Baylor University in Waco. She oversees the development, implementation, and evaluation of models of adult literacy in 3 areas: English proficiency, health literacy, and career literacy. Okay. She facilitates collaboration with other units at Baylor, church-based English as second language, adult literacy programs, and public and nonprofit organizations. She also initiates efforts to secure funding and other resources for the operation of the Center for Literacy at Baylor. And I really appreciate Gretchen agreeing to do this. She did a presentation at our workshop that we did last May, and it was a very successful program. Welcome, Gretchen. I'm going to switch now to, so you can again take a look at her as she gives her introduction. Gretchen, are you ready?
Yes, I am.
Cool. All right.
Okay. Good afternoon. I want to start by knowing my audience a little bit. So we're going to do something a little bit different with teleconferencing. If we can go through each site, and each site will introduce each person who's there, so I know at least their names. And we're going to start with UTMB. UTMB, if you can introduce yourself.
Oh, that's going to be interesting. I don't know about getting the camera on there. Okay. Let's see what I can do.
Okay, just the sound. That would be good.
The sound be all right?
Yeah.
All right, Debbie, go ahead. Get started. Oh, go ahead, Julie.
Hi, I'm Julie Kutak. I'm a PhD student at the Institute for the Medical Humanities.
Lynn?
Hi, Judy.
Hi, thank you.
I'm Linda Rounds, and I'm a family nurse practitioner, and I teach nurse practitioners in the School of Nursing here at UTV.
I'm Debbie Flanagan.
Okay.
I'm Debbie Flanagan. Hi, Precha, and I work for East Texas AHEC, and we are collaborating with Tony on this grant. And in fact, I'm a program coordinator, and I work with all of the centers that are on today.
Perfect.
I'm Tony Wilkerson. I'm a nurse practitioner. I work with the Department of Internal Medicine here.
Okay.
Susan Manello, I'm a nurse practitioner in the Seeley Center on Aging, and we do muscle metabolism studies and work with seniors on our care for elders.
Okay.
Hi, I'm Maru Computer. I'm one of the fellows in geriatrics. I'm one of the fellows in geriatrics.
Okay, good. Yes, sir?
Frank Lemus, postdoctoral fellow in Seeley Center on Aging.
Thank you for coming in.
I'm one of the geriatric fellows.
Okay.
I'm Gerardo Garcia. I'm one of the geriatric fellows.
Okay.
I'm Reverend Helen Appleberg, and I'm
And that's the
with
back of our head.
Seeley Center on Aging, and we've developed here a Center for Spirituality of Aging.
Good.
I'm Lee Rumbles. I practice geriatrics, hospice, and palliative medicine.
Okay.
I'm Tyler Raji. I'm one of the geriatricians.
And that's who we have in this room, Kretcha, for UTMB.
Perfect. Nice meeting you all. Okay, we don't have Lamar, right?
We don't have SFA. We do have Lamar. If FSA is...
We do have Lamar.
Yes.
Yes, can you hear me?
Okay, so yes, Lamar?
Yes. Yes, I'm Linda O, teaching the nursing program here at Lamar.
Perfect, thank you.
And I'm Terry Dickerson. I'm I work for Coastal AHEC program coordinator. I'm the site coordinator for Lamar.
Okay, thank you.
We also have Dr. Pearl, but she had to step away.
Okay, thank you for letting me know. Anybody else?
That's it for now.
Okay.
And then we have...
University?
Yep.
I'm sorry?
I'm sorry, I was going to help you introduce. Go ahead.
Okay. Can we continue?
Yes, go ahead.
University of Houston in Victoria.
Hi, this is Paula Crawford. I'm a program coordinator with Pecan Valley AHEC, Victoria College.
Nice meeting you.
I'm Jody Bannon, retired RN home care.
Vanessa Stevens. I'm a director for a geriatric psych program. My licenses are licensed professional counselor, licensed marriage and family therapist, and a licensed psychological associate.
Thank you.
Pam Posey. Pardon me?
Yeah, moving on.
I'm Pam
Fuzzy. I'm a social worker in a nursing home.
Okay.
And I'm Diane Beck. I'm a social worker in a nursing home.
Perfect. Thank you. Anybody else there?
Yes, I'm Ronnie Grant. I'm a student worker for APEC.
Okay, thank you. Okay, we're going to move on to the Baylor site. You want to start?
Sure. I'm Joyce Hall. I'm Director of Guardianship at Friends for Life.
Okay.
Chris Johnson, I work with skilled nursing and assisted living.
Okay.
LaWanna Harrison, I'm a registered nurse, but I do professional service coordinating for seniors at the Salvation Army and Food Garden Departments.
All right, thank you.
I'm Martha Hall, and I work for Friends for Life. I do guardianship of the studies.
Okay.
Diana Kohler, I work at the School of Nursing at Moody University.
Perfect.
Liz Flynn, I'm a nurse practitioner working at the Arthritis Clinic.
Okay.
Crystal Smedley, I'm a health educator with the Waco-McLennan County Public Health District.
Yes.
I'm Judy Lanier, and I'm Jude Lynn and Associates. I'm a life manager, consulting, personal and professional business assistants.
My name is Lisa Mosher. I'm a licensed clinical social worker in hospice.
Perfect.
I'm Janelle Walter, professor here at Baylor, teach nutrition for the aging. I'm a registered dietitian, which I know that's one of the certifications that's not on there, but that's okay, it'll work. And I'm on the board of Meals on Wheels.
Perfect. Thank you.
I'm Amanda Thomas, the AHEC coordinator.
Yes.
I'm Howard Gretzner. I'm the family care and education specialist with the Alzheimer's Association North Central Texas chapter, and background in Psych and LPC with a focus on geriatric mental health and dementia care.
Perfect. Yes, Rita.
I'm Rita Peacemaker. I'm an LVN traveling nurse for Texas Home Health.
Perfect. We're introducing each other. Each side has taken a time to introduce each other. And since we're going to do a communication skills presentation, I needed to know my audience. I needed to know who I'm speaking to. That's why I did this, okay? Let me start by thanking Dr. Tony Denuso for extending me this invitation to present on health literacy, more specifically on geriatric health literacy. I am a social worker, like Dr. Denuso said. I've been a social worker for over 10 years. And I've practiced in 3 different states. I've practiced in New Jersey, Massachusetts, and now in Texas. I started interested in this topic of health literacy because I was an interpreter translator in a local hospital here in Waco. And as a result of that experience, I began to start identifying some of the problems that I encounter as an interpreter translator for the hospital. And one of them was low literacy skills of the patients. And I would find myself often telling doctors, we need to repeat this instructions or discharge or treatment plan again because your patient is not able to understand. Your patient looks confused, they're puzzled, they don't know what you're saying. And not only to physicians, but to nurses as well, PAs, the whole gamut. I was the only translator/interpreter for the whole hospital. So I translated from the oncology department to ER, okay? So it was a really good experience, a very generalized experience, I will say, to understand some of the ins and outs of a hospital setting and all the communication problems that exist there. Now we're gonna go into my PowerPoint presentation, and I hope that Dr. Denuso is helping us in that area.
He's doing his best.
I think. Debbie was my partner last time that we did this. But the topic of the presentation is communication skills in geriatric health literacy. And we're going to go into the picture. Yes.
Sit there and find a screen.
Okay. I'm a very visual learner, okay? And I wanted to find something that would represent sort of like the communication process, okay? And I found these two heads with lines going one way and the other. And I found that that was a good representation of what the communication process may look like, because it's never straightforward, okay? It's full of complexities. And the message is always mediated by many variables and factors. And it could be many of them. It could be age, it could be socioeconomic status, ethnicity, language, life experiences, education, certainly health status, spiritual. So our communication with the receiver is never easy. And we need to start thinking that way when we embark in conversations with our patients. Okay? Moving along. These are some of the topics that we're going to be talking in this presentation. We're going to focus on the value of good interpersonal communication with older patients. We're going to discuss key principles of effective communication. I'm sorry. I'm thinking that he's managing. Overcoming barriers of communication. And an action plan to guide our practice. Tony, if you can put them all. Let me read to you some of the data that research has found.
Where did that slide go?
Research and studies show that effective communication has been linked with increases in patient and physician satisfaction, better compliance to treatment plans, more appropriate medical decisions, better health outcomes, and fewer malpractice claims. This is by the Journal of American Medical Association, 2007. So we already know this. We already know that having effective communication skills with our patients will help them to carry on their treatment plan, okay? When you help them understand, it creates a sense of, we're doing this together, you're not alone, I'm going to help you to carry this, and they don't feel as lonely as if they were to hear instructions from a professional and then they have to carry it by themselves. Some of the communication difficulties that studies suggest are that the need for patients to be more involved in the discussion of their care. So there's a lack of involvement from the patient into what they're supposed to be doing. Not only that, but insufficient information or provision of information and problems of communicating diagnosis. So it will benefit this process if you can help them figure out how will they carry out this treatment plan, or who can help them carry out this treatment plan before you start spilling all the directions, spilling those instructions, and thinking and assuming that this person is going to follow them along. One of the things that you see often in the ER specifically, healthcare setting is a very fast-paced setting. But more specifically in ER is that when we discharge patients, we often give out a very general discharge instructions, and sometimes they're not even addressed by their name. They're just printed out of the computer, and there you go. The nurse or the healthcare professional says or asks, "Do you understand?" And what will the patient say? Yes. Okay? And there we go, and the patient signs. What happens is that next week I will see that patient again with worse problems. And I think if we do the job in the front end, if we take the time to read those instructions with the patient, and then corroborate the understanding of that patient, then we will not see that patient again next week, okay? Now for that, I will suggest that you have to ask very specific questions, and not only do you understand your discharge instructions. Let me give you an example. Do you know how to take care of that wound? See, with that question, the patient can position himself going to their home, taking out that bandage, and clearing out that wound. But if you don't ask that question that specific, and you just ask the question, do you know what you're supposed to be doing at home, you are not going to get, no, I do not know. Or maybe the person understands your instructions, but they're missing some steps. Well, you can verify that if you ask very specific questions. Do you know how often you need to take your medication? Then they can tell you, okay? Whether or not they understand at what times they can do that. But if you ask, do you know how to take your medication? Most likely, they're going to say yes, okay? But if you ask the question, how often, how frequent, then it's a different answer, okay? Those are very simple questions that you can ask as a healthcare professional to verify misunderstanding, to verify misinformation. Now, the last three here encourage healthcare professionals to be in tune with patient needs, build positive relationships, and reduce stress. Let me give you more information on this communication problems. Research has found that, or demonstrated that 50% of psychological and psychiatric problems are missed. That 54% of patient problems and 45% of patient concerns are neither elicited by the physician nor disclosed by the patient. So we're missing the picture. We keep missing the whole picture. We just have half of the story whenever a patient interfaces with a healthcare professional. We're missing the boat, okay? The communication process not only conveys a set of instructions, a set of ideas, a set of thoughts, but it also conveys, more specifically to the older patient, it conveys emotional support, okay? And you can convey concern and caring with very simple things in the way that you communicate with your patient. If you're communicating with your patient close to the door, what does that mean? You're in a hurry, that you have other things to do, right? That you're thinking of something else. If you are talking to your patient with your back, okay, Miss So-and-so, I need you to do this, that, whatever. What is that conveying to you? Not interested. If you have your clipboard and you're making notes, well, Mrs. Smith is talking to you. Okay? These are very simple things that you can see over and over and over again. You're not aware, but it's the way that you carry the conversation, not with an older patient, but with patients in general as well. Okay? So that's the emotional side of the conversation when you show care and concern, and it helps to reduce stress and build positive relationship with your patient. Now we're going to move forward into key principles of effective communication. And this is a diagram used by the National Family Caregivers Association and National Alliance of Caregiving. It's a very simple, straightforward diagram. The first thing that, that this diagram has in the center is establishing presence. And establishing presence means your physical presence, your mental state, okay? How aware are you of eye contact? How aware are you of your physical posture or your proximity to your patient? All those things convey your presence. And it's very important, and older patients are very in tune with some of that. And they can pick on those nuances very quickly. It's at the center of the communication process. Now, and I'm going to make a side comment on this. There's some cultures and some ethnicities that it might be better if you get closer to them than in others. And that might be a topic for another presentation and not intended to be for this presentation. But be aware of that. Be aware that some cultures and ethnicity requires that you be a little bit closer than you will normally have with a regular patient. And it's certainly the case with the Latino patients. Every time that I will do an interpretation or translation, since I was the only translator for the whole hospital, sometimes I was in a hurry. And I often found myself at the door making those translations. Well, guess what it conveyed? That I was not taking the time to do the translation, that I was in a hurry and I was doing a poor job as a translator. See? But if I would go into the room, I would be closer to my patient, I would greet them, I would just ask a normal question, how you're doing, how it's been, and then do my job, then it conveyed a total different picture of who I was as a professional and what I was doing there. Okay? And I put myself as an example because I did that often. Okay? Now, this diagram or this picture has 3 sides. Participate actively, build mutual understanding, encourage collaboration. Participate actively means that when you go into the patient's room, you state the purpose of your examination, what you're going to do there, okay? Sometimes I will be called a nurse. Sometimes I will be called a doctor because I didn't introduce myself, okay? Oh, señorita, Mrs., are you nurse, blah, blah, blah? No. I'm your translator, I'm your interpreter, I'm your PA, I'm your OT, whatever that is. And then 2 or 3 sentences, you explain the purpose of being there with that patient. Let me give you an example. And I have lots of examples in ER because that's where I was used the most. But in ER, when you go, right, you sign your name, then you wait to be called by the triage nurse, then you wait to be called by the registration person, then you wait to be called by the other nurse, then you see a doctor, then you might see a technician to do the x-ray, then you might see another nurse because the shift changed, and you don't have the slightest idea of who is doing what to you, okay? And that was everyday life in the hospital. So by you saying, my name is so-and-so, I am this, and I'm going to do this to you, and there might be somebody else coming, okay? You prepare that patient for what is coming next. And then there might be a transporter. Sometimes they were transported from place A to place B, and they didn't know that they were being transported to place B. Tell them there will be a transporter taking you to X-ray and taking you to get an X-ray. See the difference? That is trying to participate actively in the care of your patient. If you can, try to corroborate any misinformation or incorrect assumptions and disagreements. and ask questions until you find that the patient and families understood your instructions. Then we move along with build mutual understanding. And this is where healthcare professionals have the hardest time. Often, we start listening to the patient's events and story and what happened, and then when we disagree with something, we interrupt. And that patient, your thought process, you have stopped the thought process of that patient. And an older patient, it's harder for them to go back to what they were thinking. Okay? So in here, building mutual understanding, you need to listen without tuning them out and trying to affirm them in their conversation until you get the whole story. Okay? Just listen. Now, let me tell you what research says about this interruption. According to research, physicians interrupt an average of 18 seconds into the patient's description of the presenting problem. 18 seconds. And I did this experiment with somebody at my office. I said, I want to know how far I can go in 18 seconds. And I described 2 symptoms. 2 symptoms. Now, this is what I want you to do. Okay? I'm going to be the timekeeper. You're going to have a person next to you, and one will be the patient and one will be the doctor. And you're going to present that problem in 18 seconds before I say stop. Okay? And I want to see how far you're going to get. All right? Okay, I'm going to tell you when. Oh, you have to decide who's the patient and who's the doctor. Okay? I'm not sure. You tell me. And the other side, you have to decide who's the patient and who's the doctor. We're going to run this to see if research, is proving right. I just want to know. Are we ready? Okay, everybody's ready? Yeah, okay. Start.
So what do you think, huh, Frank? Is it weird? I mean, sure. Let me know when. Friday would be good. Oh no, Friday I got a pepper. Next week.
Okay, let's start with Baylor, just to get some idea, some general idea, okay? Okay, let's start with Baylor. This area here, these people here, how many?
5 seconds to spare. I had all the symptoms, what I thought it was, in probably 13 seconds.
13 seconds?
Yep.
That was quick. You were not an older patient. Okay. Anybody? Yes.
I got all my symptoms out, and I even told the doctor what was wrong with me.
Oh my goodness gracious!
But it's because I wasn't really sick. I'm not really stressed. I'm not really talking to a stranger to try to get anything out of it. So
very good.
It doesn't.
Good point. Good point. She's not in stress. She's not fearful. Okay. She's in good health. Okay. What else?
I barely got my concern out because I took too much time getting going.
Okay. Yes.
Well, I did, I guess, pretty good with I got most of my symptoms out, well, what the problems, concerns were. But, the point that she made is very, very good because I know.
Different results in the introduction, and others were very quickly in their symptoms, and they were able to do 5 or 3 or 2.
Can I ask a question real fast?
Yes.
In relationship to this, my experience with the seniors I've known is that they really don't want to tell what's wrong with them because then they'll find out what is wrong. And so they really sort of hide things that are really wrong with them when they get in the doctor's office. And while they're at home, you hear about them all the time. So then to me, that's the real obstacle, is how to get them to really talk about, without, for them to self-reveal, without having a parent or a child who's there with them saying, tell him about, these other things, because they won't say. I don't know how many times my mother said, oh, I don't want to go to the doctor, I'll find out what's wrong with me.
And I've read that in the literature that some of that goes on, but I think it's because you need to build a relationship with your patients. Very few healthcare professionals do that. And I understand the constraints of time and all that. But if you don't build that relationship.
Another thing too is once you ask them, your doctor's asking you these questions and they're so nervous and stressed out, they forget.
That's right.
If they don't have it written down or or someone's with them to guide them, they completely, well, I don't.
So can you imagine if they're fearful, scared, they may have some problems emotionally, and then you interrupt that older patient every 18 seconds. It's just impossible for the healthcare professional to get the whole story, okay? So that's why I want you to be very aware of how these things are happening in real life and how you can bring the attention of your colleagues that this is really happening, okay, with older patients. Any other feedback from the other side? I haven't forgot about you. No? No questions?
Yes.
Yes.
I played the older adult, and I think it only took me about 10 seconds to decide I was fixated on my bowel. So, that or scenes. So, I can't imagine not being listened to when I'm an older adult.
Right. Very frustrating. Anybody else? Okay, I'm going to move on along. Let's do encourage collaboration. Encourage collaboration. And in here, sometimes social workers are called to do that part of encourage collaboration, because this is where we clarify family members' responsibilities, role, who's going to do what, when, and all that. And certainly we understand when healthcare professionals don't have the time to do that, and it's okay to call a patient advocate or call a social worker to do even the building mutual understanding, but certainly encourage collaboration of the patient as well as family members. Okay? So there you have the triangle. Let me also give you some examples of questions, okay, to clarify understanding. When you ask for clarification, you're going to ask for clarification of your own understanding, okay, of your own understanding. So you're not going to say something like, I'm sorry, but I don't understand what you're saying. Why?
Quit talking.
Because the responsibility falls on the patient. But when you ask a question like, okay, let me get this right. Let me see if I understand what you're saying. The responsibility falls where? On me. As a professional, the responsibility is on me. Okay? And you're telling the patient, I want to be responsible for this communication. Okay? And you're not going to say, I'm sorry, but I don't understand what you're saying. You're saying, okay, let's see if I can get this right. What you're saying is blank. Okay? Or I'm not sure what you're saying. Can you repeat it back to me? Okay? That's how you clarify understanding. You don't make an accusatory statement telling them you're responsible for any misunderstanding that I may have. You want to say to them, I am responsible for making this conversation going the right way. Okay? Now, we are going to see two video clips. One, it's from the MAA, and the AMA has a health literacy toolkit. on patient education materials. And we're going to see maybe 3 minutes of that video, of that resource. One will be older patients telling their experience in healthcare settings, and the other video clip is going to be about how to overcome barriers of communication by healthcare professionals, okay? Now, I really like this collage before we move on into the video clips. I really like this collage when I was doing it because I think that more and more we're serving a very diverse community of older patients. And again, this is not a cultural sensitive training, but I want to make that point and create that awareness that we are serving, and certainly in Texas, we're serving people from different ethnic and social backgrounds, more and more, okay? Let me read to you some statistical information from the AARP, their Public Policy Institute. According to the American Community Survey.
This is kind of interesting being on the receiving end, I think.
13.9% of Americans age 65 and
There's a lot that she's doing that we didn't plan.
English at home.
The video was supposed to be like about a half hour ago.
Americans, 5.3, report
And
having
I know that it's getting close to 1 o'clock. So we're going to go over and let her do what she needs to do. And I apologize if it's kind of be running over. But
2030,
this is a good exercise in communication.
to 20%.
Because I really thought we had it down. I didn't know about the introductions, which was fine. And I didn't know about the little exercise she was going to do, which was also fine. But she's also throwing in 2 videos.
Into the presentation.
We'll manage. Thanks for your patience.
That there might be some things in terms of communication that are going to be different from culture to culture, okay? And I know that we cannot know of everybody's culture, but we have to be at least aware that those differences do exist, okay? Okay, we're going to go into the video clip, and Dr. Denuso, I think you have it over there, right?
No, we were going to watch the video and you were going to move your camera
I have it over here.
from your room. That's correct.
I'm playing it twice. I'm playing it.
There you go. I don't know how much you'll be able to see. The audio is good on this. But I'm not sure how clear the video will be. But it's mostly just people
I was sick a lot.
sitting and
I was
talking.
sick a lot because I probably missed dosage and didn't realize it. I was in the hospital a lot. When they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them, and I didn't have the nerve to ask them when they did give me the right way of doing it. I just
We've lost the audio. I could also suggest maybe the other sites to please mute so we don't hear the echo. Thank you.
Oh, and then the audio, the video goes too?
Yeah. I don't know why we lost the audio. I don't know what happened. They're controlling it on their end.
Yeah.
Doesn't matter if we're muted or not. We should be able to hear it.
Me on there, and I just take it.
Okay.
Anything he tells me to take, I'll take it.
Okay. You trust him.
Oh, you better believe it, my life.
Research has shown that many patients have a hard time understanding basic medical instruction.
26% didn't understand when their next appointment was scheduled. 42% didn't understand instructions to take medication on an empty stomach. 86% couldn't understand the rights and responsibilities section of a Medicaid application.
Do you know what hypertension means, if I ask? I think, well, maybe you have hypertension and I've been taking care of that for a long time.
Hyper.
Maybe. Like you're hyper? What does being hyper mean to you?
That's where you can't be still. You always got to be doing something.
Do you think I think you're hyper? Have hypertension?
I don't know. That's what I consider it.
Okay.
Being, you know.
But you know you have high blood pressure. Okay, but hypertension doesn't mean the same to you. So if I ask you if you have hypertension, you're going to just think I think you're jumping around in the chair or something like that.
Just being hyper, you know.
If you have hypertension, you're going to just think you're jumping. Well, I haven't done a very good job teaching you what hypertension is, because I think you take that medicine for your hypertension, and that's one of the things that I try to work with you on is your blood pressure. And high blood pressure and hypertension, to us, is the same thing.
The same thing.
Yeah.
People sooner or later will discover, and that is your most greatest fear. What day is it going to be when somebody discovers you can't read and write?
So you found solutions that sort of make it work and hide the real problem.
Yes.
So that others won't notice it.
Right.
Doesn't that take a lot of your time?
Yes.
Doesn't it take a lot of effort?
A lot. Very emotionally.
Others won't notice it. Right. Doesn't that take a lot of drains you?
Yep. Yes.
Doesn't it take a lot of effort?
A lot. Very emotionally. Yep.
It drains you?
Yep.
Okay. Okay, I would like to hear from the audience what you think about this video clip, some of the things that strike you in one way or the other, and that you didn't know about health literacy. So let's start with Baylor, because I have you in front of me.
Well, no one wants to look like they don't know what's happening, so they'll go through with almost anything, it seems, just to preserve the image that they know what's happening.
That's right. They'll hide it, and they'll find ways of maneuvering that they don't know how to read and write well. Very good. That's the emotional aspect of it. And it drains you, right? Yes?
If the patient totally trusts the doctor so they can take any medication they give them, if they understand, you know, what it's for or not.
No, we have a chicken
And
salad.
I've seen this video before, but I'm always struck by the segment with the doctor, the medical professional, talking to the gentleman about hypertension. And he just thinks, you know, hyper to a non-medical professional is just being antsy and
some of these are roast
distractible
beef.
and jumping from one thing to the next. And that's just so strikes
But
me.
you have chicken
You
salad.
know, meaning of things, you know, and in the medical professional world, hypertension means a completely different thing than hyper. How that can get lost in translation.
That's right. Yes, Crystal.
On the same note, to follow up with what you said, it's true that often patients trust and place, you know, complete trust in their physician and what the physician is prescribing them and telling them to do to manage their health condition. But in some cases, when they don't fully understand what they're taking a medication for, they may not fully understand the importance of it. I've talked to people who say, well, I'm taking 1 milligram of this. That's not much. I don't really need it, so I'm just not going to take it. And they don't tell their doctor that, so they're not taking their medication. They're not improving or managing their condition. So there's really two sides where you have the complete trust. They're taking it, but they don't know why. Or they're maybe not taking it because they don't know why they're supposed to be taking it.
They're suspicious, huh? Very good. Very good. Yes. Anybody else from here? Good point. I would like to hear from the other sides if you have any feedback from the video clip. Were you able to hear it well, Tony?
I think we're okay with what you know, especially the comments that your audience, Kretcha, have brought out really helped to bring out some more ideas. Thank you.
Well, let's move on. The next one, it's a shorter video clip, and I hope that you can hear this one. This one is breaking the barriers of communication, and this is the side of the healthcare professional. We saw the patient side, and we're going to hear the healthcare professional side, okay? In terms of solutions and in terms of what they can do.
There are some things that we can do to help this. One, we need to make sure that the environment in which we deliver the care is an open environment and shame-free. Creating a shame-free environment in a doctor's office or a hospital means that there's an attitude of helpfulness by every person there.
When I walk into a doctor's office or a reception room, I would like to be treated as, even though I'm a stranger, that they know me.
Good morning, sir.
Because you're walking into what you might consider a hostile environment. It drops the defense, all the guards are down, the walls are down, the lines of communications are up.
Patients want to be able to feel safe, that they can tell the physician about their literacy skills, about their inability to understand their medical condition and receive help. Creating a shame-free environment can start with the forms that patients fill out as a screen for health literacy.
First, to identify them, short and quick, a questionnaire. 7 or 8 questions, and these are straightforward questions. I mean, we've really geared it at 5th grade level. And some of them can't answer the questions. But since the form is present on my desk, then I can immediately notice if they haven't answered the questions. So during the interview, I can bring that up. You know, my medical assistant, I noticed earlier, was helping you out with our questionnaire.
Yes. I'm dyslexic, so I have a difficulty in reading.
Yes.
And also with auditory memory. So things that I forget. So I'll ask you to, write them down, or I'll have my husband come in and whatever we discuss, so that I have a memory.
When we hand a patient a form, we don't just hand them the form and then they sit down and we kind of forget about them. So if they're having a difficult time, you can pretty much tell from how long they've actually had the form. If I see somebody sitting with that clipboard in their hand for 5 minutes, then I know that something's wrong.
I take a detailed social history, which gives me information about a lot of things other than just their literacy, their cultural background and approach to health care. How much education they've had is a big question, and I always ask people who have had limited education or say that they have had difficulty in school, I always ask them how happy they are with how they read or how well they read. And often it's as if people have been waiting for somebody to ask them that. And I've gotten a lot of mileage out of that particular question. What kind of work do you do?
I'm a pharmacist tech and a DME technician.
DME?
Durable medical equipment.
Oh, okay. And how far did you go in school?
12th grade.
How happy are you with how you read?
I'm not very good. There's always room for improvement. I'm better than I used to be. It's not my reading that really troubles me, it's my writing.
One of the important interactions that can contribute to a shame-free environment is how you review a patient's medications with them. A very effective way to ensure that the patients understand how to take those medications is to have them bring those medications into the office. It's commonly called the brown bag test. And then I sit down with the patient and say, show me how you're supposed to take these medications.
How did you get from the doctor writing you a prescription for you to getting to where you knew what pill came out of what pill bottle?
I guess, I think what I did is the recognition of letters, but not being able to read the word. I could recognize a letter, and I knew that would be my accolade. And if they're different colors and different things, that helps. But sometimes, because 2 of my pills, accolade And my tranquilizer are the same, almost the same. They're the same color, but because of the size, I have to put them together to make sure I'm not taking two of the same thing. So I try to be very careful. There are times if I don't feel well, if I'm not thinking right, I'm in a hurry, I have taken the two tranquilizers instead of one accolade and one tranquilizer.
If someone can read, they're going to pick up the pill bottle and read the label and tell you how to take it. Whereas a patient who has inadequate health literacy is going to pick up that pill bottle, take off the top, and they're going to look and say, ah, this is my oval little blue pill. This must be my pill for my diabetes.
I think my biggest asset is my front desk and my staff. They're very good at making sure that things happen in a timely fashion, and they can then give me a heads up about someone who they don't think can read.
The second thing physicians need to do is improve their communication skills. When you're trying to ensure patients understand, you can slow down. Don't speak so quickly so that the patients can understand what you're saying.
Well, you're right about the arthritis.
Okay.
It does affect the joints.
Yes, yes.
Patients or anyone can only remember 1, 2, or 3 things from a conversation. Identify what's most important to teach that patient and ensure they understand that before they walk out of the door and go home.
In the form of arthritis that you have, which is the most common, usually what happens is that inside the joint there are 2 bones, at least 2 bones.
Okay.
And the bones are just rubbing off.
Use living room language. Use language that anybody walking on the street would understand, not just the nurse and another doctor.
You mentioned earlier that you were working on your home.
Yes.
100 years old. You noticed my door. It creaks. It wears down. That door has a little oil, so it doesn't creak. When that oil wears off, it starts creaking.
What was interesting is that he used visual aids in the sense of he made a visual picture of what was going on, describing arthritis as being a joint in a door frame and not having oil. So this really helps out in the fact that you have a visual picture of what might be going on in your body.
Let's review some of these suggestions through the PowerPoint.
Rachel, can I just tell you that
yes.
It's 10 after 1, and we're going to have to kind of close this up here in a couple minutes. Is that okay?
Yes, I'm going to go just quickly through the barriers, overcoming barriers. Okay, when patients feel that they can ask questions freely and can express their concerns openly, that's when you create a shame-free environment and they're not labeled as difficult patients, like sometimes they are. Usage of non-medical terms will definitely improve and facilitate better comprehension and compliance with your instructions. We need to be aware of the pace of our speech. We cannot carry a conversation with a middle-aged person the same way we carry out with an older patient. So we need to be careful about how we use and how we speak, the rate of our speak. We need to have a complete social history of our patients so that we can know and find out more about their functional status, emotional, cognitive, lifestyle. It is very important that you don't provide paragraphs worth of instructions, but that you identify what is that the patient needs to take home. 2 or 3 things are the most important that they take home. And certainly you can use visual aids that will really help in your explanation. I often had medical residents that will draw some, small, simple diagrams of digestive system or respiratory system, and along with their explanation, they will do the drawing. And that was very assuring for patients. When every time that they had that visual with the explanation, it was very helpful for them. Lastly, there's some suggestions that you should schedule older patients early in the morning. That's when their minds are fresher and they can grasp more of the information. That's in some of the literature, that's what they suggest. And allow extra time for patients to do their social history and explanation of what's going on with them. Avoid distractions. If you can avoid background noise and people coming and going to and from the room examination, that will help. Listen without interrupting your patient so that you don't stop that thought process. Especially for those who have hearing or vision loss, you want to sit face to face. And it does improve, research shows that it does improve compliance with treatment plan whenever you are face to face with your patient. Write down instructions and summarize. I think Dr. Denuso sent some handouts, and he has a medication form and he has a visit summary form that you can take examples and use it with your patients. Okay? Lastly, this is the action plan for healthcare practitioners. If you can, and if you have the time to administer the RAPID, it's called Rapid Estimate of Adult Literacy Medicine, that's called the REOM. It's very quick. It's a literacy assessment tool. 2 or 3 minutes. It's not going to take more than that. And it will give you at least some idea of reading skills from your patient, okay? If you have the time. Try to practice various teaching methods like asking back your patient what they understand about your instructions. Plan educational programs and workshops with your colleagues. And then identify other groups that are working with this issue, like for instance the AHAC office is working with this issue, and any other agency that is worried about the public health district as well is worried about this issue. So you want to partner with those organizations that are already active in the community working with health literacy. Okay? That's my presentation, and I hope that you find it useful and informative. And I will entertain Q&A. Yes. Okay. Yes.
The form that you held up, Olga, do we have that in here?
Yes.
The test.
You should have all the handouts, right?
Thank you, Tony, and thank all of you for your patience and for being present today. I love the communications presentation. Gretchen, is that the right? I want to thank you, Gretchen, for that wonderful teaching and for giving us a chance to hear from each other. We're not going to do that again, even though I wish we could. It's wonderful to see who else is sitting about in conference rooms around this part of Texas and learning from each other. Well, as I begin to reflect on the whole question of spirituality and the healthcare system and the literacy that affects all of us, And we're talking particularly about older persons. Sometimes I use the word seniors. Sometimes I'll have people correct me and say, don't call me that, call me that. But we seem to have a real fast-growing population of people who are considered to be older than any generation before us and getting older every day. And I thought I'd just raise the question in the beginning, who are older adult seniors? Who are these people? Who are we? Well, we are us in a little later stage of development. We're people who have more physical wear and tear. Older people have more physical wear and tear and therefore have more challenges. And sometimes they're very complicated with chronic illness and health issues. Older people are more experienced and they're wider traveled. They're most often the people who are sought out because of their wisdom and more aware of their spiritual selves. There's a statement that I read just recently that older people are becoming aware of that their spiritual pace quickens as they age. And I pose that as not only a piece of information, but as a question you might ask yourself, how old am I? How old do I expect I might be, older than all generations before me? And what is this thing called my spiritual life? Now, if we were sitting around as a bunch of theologians, not healthcare professionals, we probably would say something like, well, all of God's creation are spiritual beings having a human experience, not human beings who might be spiritual. Spirituality might even be the very first component of every person, no matter what their religious belief or their not religious belief. But I just want to put those pieces, the communication of sort of collection of information in your mindset as we go forth with this particular presentation. So, now, Tony, are you going to forward me? Well, if you don't mind. The objectives for this particular presentation is to describe ways health professionals first might differentiate between spirituality and religion. And in our group today are persons who are volunteers in a healthcare setting who are going to be asking themselves the same question. Most of our volunteers have been health care providers in some way when they were wearing their professional hats. So I'll ask you to think about how we might describe ways to differentiate spirituality from religion and to address ways health professionals can bring out the spiritual needs of seniors and then make positive applications to what we know, how we can affirm the spirituality, how we can see the person not as the patient who has the physical need for a cure, but the person who's seeking to be healed at all levels of their holistic being. Now, that second objective might have a lot to do with the core values of the institution that you serve, the place where you work, what you're told you need to take care of and take care of it fast and go to the next thing. So I think we need to put that piece into all of our mental computers as we reflect on where we serve, and I'm talking to a lot of people in a lot of places. Discuss how health professionals work with older patients who might use, because it may not come up very often, but it's to raise our awareness that sometimes religion, and so we need to differentiate religion, spirituality, but whose religion might be used as a roadblock for the very treatment they need the most. When you're doing a presentation like this, I think it's imperative to interject some of the reflections written by the poets, some of the famous poets in our history. Emily Dickinson had a lot to say about life and about life as we age, but she said we turn not older with the years, but newer every day. And what the poet suggests, and so many other poets are doing this right now, and they're suggesting that we need to really think about how we want to age, what kind of quality of life we want as we age. Because whether any of us like it or not, we're on our way. Even if we're just at the beginning of what we think is our long journey. Hope is the thing that with feathers that perches in the soul and sings the tunes without the words and never stops at all. And the point that she's heading toward is to live is so startling. It leaves very little time for anything else. So I'm just inserted that thought to give you encouragement to reflect on what you think about how time goes by and how it's being spent and how full is it of all of the qualities of life. So a brief overview of religion and spirituality. And it would be great if we could stop and just talk among ourselves, but we have a lot to do this afternoon. But religion is the practical, and this is normally, religion is a practical expression of our spirituality. In other words, it's the sort of a systematic way that codifies our beliefs and our practices of what's important to us in a religious context. Rituals, liturgy, related to what we believe, who we believe, what is our belief in God or gods or a higher being. Religion may be a substitute for spirituality. Religion might be a substitute for spirituality. These are the things we look for, we listen for. And spirituality then, what is that on the other hand? It involves our existence, our relationships with ourselves, with others, with the universe, with all of creation. Spirituality is concerned with personal beliefs and values and experiences that bring life to the person. Our spirituality may be integrated with religious practices, or our spirituality might exist without having proclaimed or set ourselves into the context of a religious setting. Sometimes we might describe ourselves, or we might encounter care receivers, patients, who will describe themselves as non-religious people but have a very effective, a very active spiritual sense of their own spiritual lives, their own spiritual integrity about who they are. So then we go to the next slide and look at the initial spiritual assessment. In so many places now we're beginning to introduce a spiritual assessment as foundational and important to the care of the person, whether they're a child or they're an average adult of some medium age or an older adult. But since spiritual issues seem to be more and more prevalent as people age, it seems that it's more important, or it's a vital component of the present world of caretaking for older people. And in an assessment, we look for indicators. Now, in a little while, we're going to have a panel of volunteers who are going to have a chance to talk about how they are trained or how they walk into a patient's room, noticing, and please let me include, as I talk about seniors, as I talk about the older person, I want to include the family component, because in our particular ACE unit, we encourage having family remain with patient. So we have a combination of the professional caregiver, those who come from the medical perspective, I'm the doctor, then here comes the nurse, and here come the aides, the assistants, all the different persons who are called in for the procedures. And at the same time, we have the one patient, but we have the family sort of wrapped around the patient who want oftentimes to take control of the whole setting. And the patient's the last one who gets to speak. The patient's the last one who gets to say, but what about me? We're all in this room because of me. And I think in our communication skills, in the whole literacy issue of healthcare, to be very conscious of and balance the reaction to both family and care receiver, or the initial patient. So we look for spiritual and religious indicators to know something about the spirituality of the person. And I want to say again that intentional looking for and taking care of will have a lot to do with the core values of the institution where you serve. If you're hurried and pressed to get one thing done and one thing only, take care of that disease and don't worry so much about the whole person, then you might not stop and notice that that man or woman is clutching a cross or holding on to a menorah or begging someone to please come and pray for them. We'll find somebody later. Right now we need to get this medication started. So being aware and sensitive to what's really happening in the room that the person receiving your care is pleading for you to notice. And I hope the volunteers will be thinking about some of the situations you have encountered that you can share with our broad audience this afternoon. And you're listening for spiritual remarks, you're looking for spiritual accoutrements, those kinds of things that are brought into the room. You're looking for family pictures. You're looking for anything that might indicate what's important and valuable to that person. And take the time to pay attention, to let that person know that you care about who they are, as well as the disease or the condition they happen to have at the time. It's very important in most cases, and I think most caregivers do this, will ask someplace, not just on the interview sheet when you're being admitted, but with words and with intentional care and compassion. Would you like for me to call a chaplain while you're here? Would you like to see someone of a spiritual nature? And that chaplain could be, and hopefully most chaplains are trained to be open to people of all faiths, not just one faith. Some people will move away from a person if they discover they're not of the same religion. And that can be very frustrating to the person who's not caring about what your religion is as a nurse or as a doctor, but will you listen to what I need? Because for my healing and for my cure, I need somebody in addition to you. So I think that's one of the things we can listen for and be aware of as we provide care for our patients today. Some of the other ways we can go about communicating those concerns is to explore with the patients what they value, what gives them joy, what kind of peacefulness is important to them, what brings them a sense of calm and happiness. Most of us have discovered that when we listen to the story, and if you'll discover that the wisdom and the experience of the 90-year-old man or woman will come out if you just say, well, tell me about your family. Or what has life been like for you these wonderful long years? And it will be very difficult, and it is for many of us, to find a place to say, let's hope that we can talk later, because the story will go for a long time. There's so much to share. There's so much to tell. But that's one of the reasons we try to have the opportunity for a volunteer who has the time and will give the time to hearing the story. But we explore with patients what they value, what gives them joy. We ask what creative work they do. How do you use your hands or your creative skills? Or have you been enjoying music most of your life. We will bring a tape recorder into the room if somebody wants music to listen to. A nurse will take care of that. If there's any equipment around that's accessible for the patient, we will bring that to them to answer some of the needs that will give them a sense of being at home, of comfort while they're in the hospital. But in listening to stories, we ask them what gives them strength. What is the thing inside them that gives you the calm and the strength for difficult times? How have you met life's challenges and events? Now, somebody may claim not to believe very much of anything. Then you might want to know, well, what has been the ultimate influence in your life? The point I'm making is we don't turn away from a person because they don't do spiritual talk. We don't leave them alone because they're not interested in either religion or spiritual matters. But we give them a chance to say who they are and what is valuable to them. Now, the role of religion, and some of you may be thinking, well, I don't know what religion or spirituality has to do with my taking care of a patient who is in great need of this particular procedure or this process of care. You might say that because you're so concerned about helping them come out of the situation they're in, so that the focus and the time is so short and there's so little opportunity to look at the whole person. It may be just an expression of, I hope the visitor, the volunteer gets to come and see you today. Or how can I be of help? The social support, the social worker, if the social worker is able to get to that person, they may not need to see that person for any reason except to be with them for just a short time. But a sense of belonging through religious affiliation is one of the things that is so vital that the patient wants us to know about. The role of religion and spirituality and health is significant in coping with the setbacks, with a long period of time in recovery of, I have to say, breaking a hip, and we use that example, and the time it takes to wait until a person can truly be independent again, going through their different levels of therapy. Now, the issue of spirituality and ethnicity. Being aware and sensitive to the importance of the relationship between religion and ethnicity. And I only have pointed out a few kinds of connections. You think of the connections that you have experienced, we can make the list much longer. Elder Native Americans, to be able to live the past and reconnect with that which has created them may be the most important thing that a Native American has on their mind, and they need to talk about. They need to feel that somebody knows something about their background and who they are. The African American community, and these are just results of so many studies of the African American men and women who have been in the health system, that the church comes with most of the men and women. The women especially would say that my church community is, in addition to my family, one of the most important communities in my life. And we will address that among us when we have our panel, and what that means to the people who are in our care, to recognize that and to find some way to say or to encourage, and in most places encourage the church family to be a part of that person's daily care, their prayer life, coming and praying with them, coming and singing, coming and doing what church families do for each other. And that has to do with the family around the patient in many, many different ways. often found in the Mexican American women, and this particular statement is about women, it'd be men too, but women much more so, that the religious and cultural traditions are so foundational to the way they are adjusting to perhaps being new in this setting, in this country, and also in the sustaining of their family life. But these are things that we can study and know more about, and these are the kinds of, this is the kind of information that can help us be sensitive to ways to connect. And oftentimes, particularly when there is a language barrier. So I just wanted to mention those particular points. Now, religion as a roadblock to treatment. Mental and emotional problems can be, this is not a statement of reality unless you experience it, and it seems to happen more frequently than we know. But sometimes with an exaggeration of the religious or the spiritual practice a person has in their tradition, may be that sort of block or covering to prevent or try to keep the caregiver, the doctor, the nurse, away from discovering the real deeper emotional problems that may be going on in the patient's life. Now, sometimes religion is substituted as a form of denial. And you can think of examples when that might have happened to be. But I wanted you to be conscious of that as blocks for communication. What gets between you and the patient that may have a religious overtone or a religious covering, that sometimes, rather than face the reality of the condition of one's body and life, that the denial is covered over by knowing that someplace there will be divine intervention for them, and that the religion is their one strongest strength. And that may be the one truth that can be the foundation for helping and supporting the family to find the reality in the next step of looking at end-of-life issues and of looking at the need to bring in hospice or to begin to prepare for that person's death. Just to take this a little further, religiosity as an addiction. And I think these are some of the questions, and we haven't talked about this a lot in our volunteer group, but you might think about what you've heard people say as you try to visit them, and the conversations just keep going to a dead end into the you know, you can hear people talk about how their quality of their life is improved or deteriorated. Listen for whether their religious beliefs provide peace and personal contentment, or are they being argumentative or self-righteous and pushing away the possibility of the good side of their religious belief, that somewhere what has happened to them is some kind of punishment or something harsh that's happening to them. And this is where the religious zeal and religion and spiritual zeal will coincide with a sudden negative personality change. And those are things we can listen for once we're aware of them. And also listening for how that person's tolerance for others' points of view are declined. People whose behavior and emotional approach to their lives and to you will change. And the covering or the disguise will be a harshness against God, against religion, against anything spiritual. And how do we deal with that? To continue what we learned in the previous teaching, to maintain, it was the center of that triad we looked at, to maintain our presence, to be the gentle, compassionate, caring presence of the caregiver, no matter how the patient tries to push us away. when we move to the next slide, we look at the direct effects of religious beliefs on treatment. A lot of these things we can't do anything about because it's already written in stone in the religious practice of a family's life. Some of you may have experienced this many times, or you may have these kinds of notes written in your own chart for your own life, if this is your religious belief. But prohibition against receiving a blood transfusion in any situation. And how do we deal with that in the face of where the family stands over and against helping the patient? Prohibition against the practice of psychiatry or the use of antidepressants. The belief that illness is a result of sin, that God is punishing, and that this person has broken all the rules, and but faith and confession will make them well. So illness is related entirely to behavior. If I have done this, this is going to be my condition. But if I will do this, I will get better. And the conflict and the confusion and the frustration of trying to communicate with both the patient and the family under those circumstances can be one of your greatest challenges as the lay visitor, as the healthcare provider. And so to be conscious and aware that this will happen in time if it hasn't happened already. And this is when you can call a chaplain. You can say, well, who is your church leader? Who is your religious leader? Let's sit down and talk about this and give yourself an opportunity to not have a triangulation, but to have a triad of care. To have some way to provide a broader base for getting the person, the family, the patient, the family, to talk about where they stand with this particular basis of belief. One of the most difficult things in our profession is not to stand in judgment over and against one or the other, or to take sides, because we may believe very strongly the same way that somebody else believes. But this is not our time to suddenly become something we're not intended to be. And that is the advocate on a religious or spiritual part of a person's life. Are we okay on time, Tony? Okay. I think there was one point on that last one that I might have missed. No, I think we did that. I just want to be sure. Okay. Oh, and the last one was the belief that if you pray long enough and have enough faith, you will be healed. And sometimes that is the only pathway that a person has ever known or experienced in their entire lifetime. And the doctor, the nurse, the person providing the care, the hospice person, stands ready to be with and to show compassionate care and love for the family and the patient, who must do what they must do to live out what they believe is the most foundational part to their spiritual journey. They'll see spirituality and religion as one and the same, and that is the way their lives need to go. So just keep that in mind. In conclusion, the role of spirituality and an elder person's participation in their faith community will and does have a very direct impact. I've used the word positive here. And it will have a positive impact, or it could have a negative impact on that person's health. And that's really not ours to judge, but ours to be aware of and to be open to. And to continue to treat the patient and the family with the same sense of dignity and respect and support as they wrestle with their own predetermination of where their lives are in their spiritual journey, and as they face their perhaps answers to very hard questions about the continuation of life, about life support, and about where they're going with their futures. And one of the people who has written a great deal, her name is Lisa Chippendale, has asked this question, and I just leave it with you: is the only goal of spirituality in aging to maintain better health? I don't, you know, she just threw that out there, and I thought I'd throw it out there. What is the goal of spirituality? I think that would be better for us. What is the goal of spirituality in aging? What is the goal of spirituality and religion in aging that will give support to better health, better sustaining relationships, more openness to being willing to listen to each other, and to be and to listen for that and to encourage it, so that we're part of that conversation. I think most of all we're discovering that the trend today is to approach aging as we all are trying to do and discovering ways to do. It's not only a new and challenging, unique stage of life, it's a stage of life that is writing its own story, that's creating its own history. And part of our work in the gerontological world, the Seeley Center on Aging, and all the different components of the work that all of you in all these various places are endeavoring to make vital in the community, and that is to raise the awareness of the prospect of living longer and how we can live longer with greater health and a greater sense of respecting each other in all the facets of our lives, but most especially from the perspective of where I speak today of the spiritual and religious life that is definitely a part of the holistic identity of every human being. Thank you.
We have time for a couple of questions. The other sides can unmute and participate in a little discussion.
I'd love to answer any questions.
I did want to point out, if I may,
oh, there was one more conclusion.
Want to talk about that?
Well, I didn't even. I forgot that we even slipped. I kind of jumped over it. Yeah, let's look at it for a minute. Stir up another question, maybe. Back up one. Yeah, it's all right. Too many numbers. Now, these conclusions are not based on my deciding to work them into the program. These conclusions come from so many studies that have taken place, and much of the research that we're aware of and are connected to. But people, seniors with strong religious or spiritual beliefs, will heal faster from surgery. They seem to be less anxious or depressed. Lower blood pressure, especially those who practice what they say they believe. Practice, if I say that I do meditation every morning, and I really do, whatever you hear a person claiming to do, you will notice their blood pressure is lower. They're calmer. They're able to listen better because they're not so worried about themselves. We're talking about how to reduce stress and how to reduce anxiety, and this whole thing about life is all about me. A lot of spiritually strong and religious people are not so worried about themselves. They've sort of given themselves into the mix of knowing where they are and who they are. So those four statements about religious and spiritual beliefs have pretty well been proven out by the very combination of what we've studied and what people do. And they cope better with their chronic illnesses. That's one of the toughest things about getting older, and that's having chronic illnesses and how to live with them. Regular religious attendance, and I was really surprised at this, but and I haven't been able to find a lot of information on some of these studies, but I bump into them over and over again, that life expectancy bumps up 7 to 8 years in the lives of older people who are just not going to miss being there for the coverage supper, or for the Mass, or for the synagogue gathering, or for five times of prayer a day as Muslims. Their faith and their practice of their religion absolutely coincides and correlates to everything that keeps them strong. And they just live longer. So you might want to pursue some of that yourself. It's fun to know some of these things when you're spending your whole day working with older people. To have some kind of encouraging thing to say, did you know? Characteristics such as faith, hope, and forgiveness, use of prayer, and social support. Social support meaning real connectedness. Real connectedness. When people let you know they are still connected to their old friends, to their old tennis buddies, to the folks that they did summer camp with, to the people that they sit in rocking chairs and play dominoes with, that they have a structure of some kind of social connectedness, and that they get up and put their shoes on and go to church wherever they worship. That those people, all that combined has noticeable effects on their physical and emotional health, their optimism, their willingness to accept the truth, their willingness not to be pessimistic and downhearted about everything. And I think that's the foundation of it all. So now, any questions? Take care or serve or treat a patient who's saying, there's nothing that anybody can do for me. Whatever happens to me is in God's hands. I've seen that happen in some situations. As a chaplain for a lot of years, being the third party in a room or outside in the hall, or having been in a visit and then I go out and the doctor comes in, or whatever, or the nurse is there. And the question, well, I hear what you're saying. I believe and trust that you know your faith and you know where you stand. But is it possible that what I may have to provide for you is part of that plan? Let yourself be one of the subjects that may be one of the provisions that God has given to that patient that will help them receive that reality in a more complete way. What can I do to help you be comfortable? What can we do? Because there are the boundaries that have to be respected at some level. And yet I think by being vulnerable to the patient, if you find that that's possible, and many times it would be by being vulnerable to say, how can I be a part of what you feel God intends? Because I want you to get the best care you can have. That's what I'm called to do. And so rather than argue with that person or that, and you will most times have at least one or two family members who are the cheerleaders on the opposite side, saying you just got to do what Daddy needs no matter what Daddy says. Are you with me on that? That there's always going to be the advocate for the other. And so, and it puts the primary physician, the caregiver, in a very delicate place. But I would say the caregiver has every reason and every promised right to stay firm and planted and even be a silent contributor to, I stand here as long as I know we can do something that will support you. Sometimes the word treatment and this medication and this action right now can be shifted into different language. Would any of you want to comment on that? Or yes?
Could I just follow up a little bit about what you said about being vulnerable to the patient? And I'd like to think about it in terms of the healthcare team and the compartmentalization of tasks when you're caring for a person. I think that I feel like it's easy. It's been easy for me as I've seen it. That if someone says it's in God's hands, that you can say, oh, good, I don't have to deal with that question. That's a big, hard question. Or I'll send that one over to the chaplain, or that's something for someone else to talk to. Can you talk a little bit about what the responsibility is for each person, and at what point does it go beyond your designated role and fall to someone else?
I'll just give you my own experience briefly and my own opinion. That's about the best I can do, because I can't speak for for healthcare systems and what's in place and what is acceptable and not acceptable. All the years I spent at St. Luke's and Texas Children's Hospital in the medical center in Houston, all those years I watched the interdisciplinary team formation be the primary design of caregiving, so that I was never the chaplain by myself, or the doctor was never he or she by himself, or the nurse or all the other persons in the care system, from the pharmacist, right down to the person coming in with checking the blood pressure, whatever. And so being a part of an interdisciplinary team really does give you a conversation and a consortium. Now those two things are, you have a conversation with your caregiving team and you have a consortium of care. It's not one individual over and against the other, but it's all of us together. And I've had situations in personal experience where the doctor would come and say, I've done all I'm going to do. We've done it all. We've looked at every paper. We looked at every release, and this is what we're doing. Now, if you want to stay, stay. And this would be after a family conference. And we did lots of family conferencing with patient care concerns, because those are tertiary care hospitals. And I found that it was the interdisciplinary work, and that included the volunteers. That's why getting to work with volunteers here was so exciting for me. When you dismantle an interdisciplinary care system, or you don't have the qualifications or the qualities of what you want because of conditions like the one condition we're in now here at UTMB, and I'm just speak to our own immediate place, then it's very difficult to have that kind of interdisciplinary support. And so, because you cross all lines of religious differences and all lines of different trainings that people have had. Oh, I was only trained to do one thing. No, we're all trained to listen to each other and then to do the best care we can for the patient right to the very last. And I really encourage that, whether you have it formally from the systematic top down, or whether you have it corporately from within a department or within a floor. One little point I want to make, I wanted to mention that, but it didn't come into the mix today, because it's on my mind, just almost every day coming to UTMB, seeing how split life and care has been because of our loss of so many silos of care. And I think everybody's heart and soul and temperament and training want so much to provide every patient with the very best we can give them, no matter our condition. What I was going to mention is the article that was referred to today by a lot of our nurses and caregivers who are talking about their lives right now in Galveston, Texas, in relation to trying to come back and be as completely whole as they can be to provide the best care. A lot of the nurse managers are quoted in that particular article. And their concern is, I just want to do for the patients what they need. And even if I don't live in my own house and I don't have anything, but maybe I'm still in a motel. And is anybody in a trailer that's sitting here? Now, you folks out in the rest of Texas may not know that we have some people living in trailers because there's no other place to live. So it's not a laughing matter. But anyway, I just wanted to, I think interdisciplinary care, and that's not the only answer, but I think it's one of the best solutions for having the strength, because you are strong, much stronger when you're collaborating as a team.
You're going to have to get set up. The only thing I'd like to add is that I think these kinds of conversations and get together, for me at least, help move towards.
Thank you. I love getting to be a part of it. Thank you.
Okay.
Well, for the last gathering, for the last lecture presentation of today's program, we've convened a panel of volunteers, We have men in our volunteer program, but none of them could come today, so we just happen to be all ladies. Marilyn Brodwick, the person on the other end of the table. Marilyn, hold up your hand. Marilyn and I have, for the last 3 or 4 years, I've lost track, but we've been on the journey of organizing and training and convening men and women who can be of any age, but most of them seem to be persons who are aging well and are on their way in some dimension or other, and therefore have said, yes, I'd love to be a volunteer on the ACE unit at John Seeley Hospital in UTMB. Now the ACE unit is ACE, Acute Care for Elders, which about 12 years ago was initiated by Dr. James Goodwin, who at that time was the director of 2 things, the Department of Geriatrics and also the director of Seeley Center on Aging, and has led the way in inspiring people around the country to set aside or designate a special area in their hospital for the care of elders. And we've been so proud of our acute care for elders. These ladies, all of you, and I'm going to ask you to introduce yourselves, and you're going to have a mic, it's right there in front of you. But speak out your name and about how long you've been volunteering, which means at least once a week. How many of you come twice a week? I know you do, Linky, and several others when they can. Last week we had a 2-hour continuing education gathering because we meet every month for continuing education. Listen, have speakers and programs because we want to grow in knowledge and understanding of the whole wonderful experience of becoming more elderly, of aging. And so, like, for instance, last week we had our 2-hour gathering for education, and then several of the women came back to the ACE unit on Friday afternoon to sing love songs because it was the closest day to Valentine in a weekday we could get. So we believe in doing a lot of things as volunteers to bring a sense of caring and compassion and the generosity of being met by friends in the hallway and by having somebody will open the door and say, would it be okay if I came to visit for a while? And that might mean inviting that person to go out into the hallway or to one of the tables in our, quote, living rooms. We don't like the word waiting room. And go out into the living room and play a game of checkers or work a puzzle. If the patient's in bed and doesn't feel well enough to move or cannot ambulate, then, well, they're going to tell you. I'm not going to tell any more of their story. But as we have this discussion, we're going to talk about some of their concerns about having access to the literacy, the communication of what's for them as seniors, and that's one of our major concerns in this component, and also what they do to be that bridge of communication from the community to the hospital, to the patients, and to their families. So if I could begin with you, Teresa, just tell us your name, and a lot of you have been caregivers in different places in your life. So if you would tell us something about yourself, just a little bit, so we'll know you better.
My name is Teresa Franks, and I've worked on the ACE unit once a week for about the last 4.5 years.
That's a long time.
Yes.
And in your professional life?
I sold real estate.
Wonderful.
My professional life. I raised 4 girls. I think I'm still raising them.
We continue to raise our children no matter what age they are. Wonderful. Thank you, Teresa. You don't need to touch it. It's on. No, and so next. Well,
okay, I'm Florence Henderson, and I always said I had the name before the one everybody else knows, until I found that was actually her birth name, so it was mine since I married some 60, oh Lord, anyhow, some 60 odd years ago. And,
your professional life?
Well, professional life, I was a public school teacher. But thing that attracted me when she issued the call for volunteers for the ACE unit. I have reached that senior citizen station where so many of my friends are gone, others are in bad shape, and I get to the place where, you know, what else can I do? One needs to have to feel useful. And all the things she listed, to listen to patients, or talk to them, or do puzzles with them, or play the piano, and that's 3.5 years.
Yeah, but playing the piano is one of your favorite things.
Right.
And we love it. She says, music or no music, and she sits down and by the way, we have piano. When we had a full unit, we had pianos on either wing of the unit. We only have one wing of that unit right now, but we still have a piano. Thank you, Florence. Go ahead, Betty.
I'm Betty Bennett, and I'm a retired occupational health nurse, certified occupational health nurse. But I did work here some at UTMB. I spent most of my nursing career at St. Mary's in the OB-GYN department and floated too before that for ball. So I got a general idea of what all the went on each unit of the hospital. And anyway, when I got an opportunity to nurse in the plant in the oil refinery, all new stuff to me, all alone, no doctor, no nurse, no contemporary. I met a lot of people that were getting ready to retire, and so I learned about people's plans and everything for retirement. So pretty soon, I had to retire because my husband was kind of disabled and staying home, and I wanted to be with him. And then when he passed, I started volunteering here and there. And then later years I found out about the ACE unit, the adult care for the elderly. And I said, I think that's where I need to be. And so I was there from the beginning.
Yes, you were.
And I felt like, Dr. Appelberg went around the room and asked why we were there. And I told her that I hope someday somebody would come and visit me when I was in the adult care unit. And so that was why I started volunteering there. And I have gotten more than I've given. I just think that it's just been wonderful for me to be able to say I volunteer, but because I've gotten so much out of it, like singing last Friday. Those patients, we went around and sang those old love songs to them, and they were eating their lunch and had visitors and everything, but they just glowed. They were so happy for us to be in there singing to them.
That's wonderful.
It was just a good experience to say, I made them smile. You know?
That's wonderful, Betty. Thank you. Thank you very, very much.
My name is Minky Wells. I've been on the ACE unit for 3 years.
Mm-hmm.
I didn't sign up for the ACE unit, but that's where they put me. I don't know how I got there. But I enjoy it. You know, I get a blessing out of visiting the elderly. I'm elderly too, but the sick elderly people, you know. And sometimes you go into some of the rooms, they want to talk, and you have to sit there and talk with them, you know. But I put in 3 hours each day. I go Tuesday and Thursday, 3 hours each day, every week, you know. And and it's a joy to visit and talk to them, you know, and if they want something, get it for them, or whatever they want, you know.
Okay.
It has been a blessing to me, and hope it has been a blessing to them, you know. But I really enjoy working with the issues.
I'm Olive Creel, and I enjoy working with the ACE unit. It's just really been a wonderful thing for me. I'm retired from UTMB. I worked at the School of Allied Health in the school at the Office of the Administration, and I enjoy working with the ACE unit. I get more out of it than I think the patients get out of it. Yeah.
We do have a lot of fun, don't we?
Yes, we do. And I've enjoyed being with this group. I think it's done a lot for me too.
Good.
Well, I think I'm Marilyn Broadwick, and I work with Helen in the Sibley Center on Aging. I've been here 16 years doing a variety of things from research to more recently the volunteer registry.
The ACE unit volunteers represent the connectedness. I think let's make that a point for those who might not have thought that there would be a good way to encourage keeping healthy by staying connected, which is so basic, and providing care, getting outside one's own concerns and self to be there with another person. One of the things we say when we send out put our brochures around the campus and around the community and say, would you like to become a friend of the ACE unit? That's what we call ourselves. One of the things we say is, in what ways would you make a difference? Nurture patients by serving as a listening presence. That's what better way to communicate your care than just to be there, to listen. And to bring comfort and companionship. Being in a hospital all by yourself, especially if you've been brought from a nursing home to the hospital and your family is in Ohio or Illinois or Florida, having somebody drop by day after day just to be with you can enhance your recovery in enormous ways. And then to follow that, help to diffuse loneliness. So we're just touching those touchstones of what being a volunteer is all about. We would appreciate, I think all of us, those of us in this room and in the other rooms, conference rooms around the other locations, help us to and think of your own experience. Identify the health literacy needs. If you can, think about the health literacy needs of older patients based on their experiences. What do they tell you about their need for a communication that they want from the agency, the hospital where they're being served? Just think of experiences, if you would, of what you hear patients say as they express what they need from us and how you can be that messenger back to the community. Even to go back and see the nurse and tell the bridge back to their immediate caregiver. Maybe you've had some of those experiences. Or they're asking you questions about their own spiritual needs. And you will be able to say, well, let me sit down and listen to your story and what you've heard in those stories. Or how you've said, well, I know your pastor or your minister or your rabbi. I'll go and pick up the phone and call them and give them or make sure that that's approved by the nurse to get you the support you need. You want to offer some of those stories?
Well, each one of them are individuals. You have to treat them as such. They're all different.
Pardon me? Yeah, speak out.
All the patients are different. You have to treat them differently.
So the uniqueness, yeah.
Yes, and having been raised in Galveston, I find it real easy to talk to them because so many of them are from Galveston. And they want to reminisce. They want to reminisce about the past. And since I'm as old as I am, I remember quite a bit. So I sit and visit with them. And if they want to visit for 30 minutes, I'll stay in there for 30 minutes. Because it means a lot to them. And they love to laugh. If you can keep them happy and make them laugh, that's a big help in their health, health-wise. I honestly believe that laughter is the best medicine.
You've touched on one of the major, at least as I watch, as I observe, and Marilyn could testify the same thing. Being on the unit when you all are coming and going and to hear the laughter coming out of the room, the stories that stir up all these memories, and people forget they're sick, that they're hurting. They forget the pain when they hear the music and when they hear the laughter. You want to tell any other of the humorous stories? Do you think of one of the men who's no longer with us, the two guys that would go in and out of the rooms?
JB.
Yeah, do anybody want to tell one of those stories? Well, I just suggest.
I think we're all senior
We,
citizens too.
as you can tell, if we'd rehearsed, we'd be stiff. But we're just not connecting sometimes.
Helen, I can tell you a story. It's not a humor story, but one of my experiences, it was a lady that was about 102 that I was visiting, and she seemed in great shape, other than she was in the hospital. And I asked her, what did she attribute her longevity to? And she said, well, I read the Bible every day. And I said, oh, are you reading it? She says, no, I don't have one here. And I said, well, I could get you one. And she says, but I don't have my glasses. And
hadn't she come through the ER? Or she'd been admitted through the ER maybe in a hurry?
No, well, I think she had come from a nursing home.
Oh, okay.
But anyway, but she didn't want to bother anybody. So here, this is somebody who, religion was important to, and the Bible is important to, and here she probably needed it the most, but she didn't want to impose on anybody. And so even when I realized that a relative could get the glasses, she didn't want to bother them. It all got resolved, but I thought that was just like a little thing to do that made this huge difference. And that not all patients will complain or say what their needs are.
That's a great story, I think. Because your sensitivity, by asking questions, the kinds of questions, just simple, friendly questions, allowed her to let you take care of the one basic thing she needed to do and to have. If I remember it, before the sunset that day, her glasses were on her face and she had her Bible in her hand. And she didn't need to go through the night, being so alone and without the very things that sustained her. And I'll never forget, that's a beautiful story. Where I was going with the humor is that one of our ACE unit volunteers is a gentleman who, because of his own physical condition, about 2 years ago died on the same floor on the unit, and felt so at home there, because he had spent at least twice a week with another with another one of the men volunteers, and this particular man would wear his baseball cap backwards. He was just a comic. And he and the other gentleman would just go into rooms and just walk into somebody's room and say, good morning, how are you? And within seconds, they were all laughing. And then they would laugh, and then they would laugh some more, and then they'd go to the next room, and you could just hear, you could feel everybody, and then the nurses and everybody enjoyed them. And we have found, I think, mentioning humor is just foundational to the change we can make without having any tools in our hands. Yes.
Reverend Applegarth, one of the things I'm interested in is y'all came to volunteer through certain needs that y'all had and wanting to meet the needs of others. What kind of training, talking about the continuing education, what kind of training do y'all receive to go through what it is that you do with these patients? What have you learned?
What was one of the primary things we learned about what we're intended to do when we enter a room is to
listen. And I think you first have to ask them if they even want you to come in there.
Yeah.
Because there are a lot of people that really don't want you to. And you have to respect that and say, well, that's fine. Or if they're busy, you say, well, maybe I'll come back in a little while if you would like for me to, or something like that. But you have to respect people if they don't want you to come in. And you have to kind of hear them out and see what they really want you to talk about, because now, for instance, you can't talk about religious things because you don't know what is their religious belief, or even if they're having a religious belief. So you have to know that, kind of listen to them and kind of feel them out before you start talking about it.
I think we do a training course of it's just ongoing training, but we spent at least 4 sessions with a little training manual that Marilyn and I put together before they began volunteering. We practice how do you enter a room, how do you leave a room. Yes. Primary purpose is to be open and available to listen to what the patient needs, to be conscious of what the family needs, and to find our gifts. If I'm not comfortable, like if Betty had said, I don't want to go into rooms, I don't like, that's not my cup of tea. Then or with Florence said, I want to play the piano. Well, Florence gets to play the piano. I like working puzzles. And if I can sit out in the living room with the big aquarium there and put a puzzle on the table and start working it, within 5 minutes, a patient will spot me and come over if they're out, if they're ambulatory, and they'll come and sit down and we'll all begin talking and working that puzzle together. Some of you have done, you do all kinds of things.
Maybe not just the patient, but some family.
Families love it.
I just love visiting.
Get out and visit with
I get a lot out of it. I go home and thank God I'm not in that bed.
I've been there.
We love, one of our main premise is to create a home-like environment. Everything about the ACE unit is to help people feel comfortable and at home. And there's carpet on the floor in the living rooms. There, as I mentioned, the aquarium, sofas and chairs and tables, and things to do, books to read, a
CDs.
television to
we
watch.
Have CDs there.
CD player.
Sometimes we have to help them eat. I had a gentleman one day that couldn't get a fork in his hand or anything, and I said, well, I'll feed you. So I was feeding him, and he said, you know, this is great. He said, my wife has never done this before.
And we have some instructions about that also.
Yes.
Well, maybe you haven't asked her. He said, yeah, that's right.
For about 3 years, we had a nurse who specialized in the feeding program, and she gave us the skills for assisting with meals. And we were supervised, and you were, when you felt you knew how to go slowly, and the nurse knew that you were doing that feeding, that you were there. You always kept the door open, so you could always get help if the person had difficulty swallowing, had any choking issues. And that sort of thing is going to be more and more critical in the volunteering world, because we have so many people who are older and more feeble and need assistance of that kind of family-friendly support rather than the medical, and who has time as a nurse or a doctor to see everybody and do well with them and also sit and patiently help somebody swallow little tiny bites at a time.
And we have less nurses right now, too.
We do seem to have more patients per nurse or per caregiver. Linky, what are some of the things you enjoy the most with your people? Because you're here twice a week, just quietly going in and out of rooms.
Well, that's my enjoyment, just going in and talk. There was a lady, she's gone on now, she's not anymore, but I had to go in her room every day and sit 30 minutes or more. I could hardly leave, I enjoyed doing it,
But she really expected you.
Every time I come there, she was looking for me. She said, I was wondering where you were, okay, here I am. And then you go in, and as you say, we go in and we talk to them, get whatever they need. If they want something, help them with something. Like the feeding, I can't do that because I didn't take the class. In order to do that, I have to take the class to do that, But whatever a volunteer, whatever I can do as a volunteer, I can do it. There are some things we can't do, but whatever I could do, I do it. I really enjoy it, It's just good to go in and know that you are making someone else happy, or you can do something for someone else, and doing it because you love doing it, And this is where I look at it,
That's wonderful.
And when I miss, I told what's her name down at the registration office? Vicky. I told Vicky, I said, Vicky, I'll be out for one day out of the month. I won't be here. I said, but I miss it. And I said, well, I ought to go another day because you told me I could go another day if I missed the day I come, but I haven't done that yet. and they haven't started back, and I think they have they, Doctor?
No, we haven't. No, we don't.
But I'd be glad when we can start back and going
That's
back
right.
up there, you know.
Things are not the same.
You
right
know,
now.
but we have been.
I would like to ask all of you in our meeting rooms around the territory, please ask any questions of this panel, because they can supply you, I think, with a lot of creative ideas about what volunteering must mean to patients in this particular world of aging. So would you ask any questions now? We'd be glad to entertain those questions.
And we also have a volunteer dog up there. Tilly.
Tilly.
Tilly she goes into the rooms, and like she go to visit, she come on back out and she makes her round like everyone else.
And I understand she's coming back.
Any questions from all of you? If you want us to help you start an ACE unit, we'll be glad to do it. We're very grateful that we've had that opportunity. We've had that encouragement to flood the ACE unit with volunteers. Those were my instructions from the doctor I work for, because he said that will make a difference, and we feel it does make a huge difference. Anybody?
One thing I was thinking about, is that right?
Oh, we are on, okay, what about children? Do you ever have children that come in and visit with the elderly?
Yes. We do when we have permission. We have to be very careful about the guidelines of the hospital, and we have children, of course, who can visit their families on the ACE unit at almost any time. But regular visitors have to be 14 years of age or older. And we've had some teenagers in the summer from middle school, and we would if anybody's listening, we'd love to have more. We love intergenerational work because that's so foundational to communicating to elder constituents that we are a family. We are truly a family, and the more family communications we can have, the more integrated we feel, the less separated we feel. Thank you for that question. Anybody else?
I was going to ask, about how much, do you have a lot of interaction with the healthcare staff on the floor, in terms of like the types of things they would ask you to do or to give to the patient, or and the listening's important, but how much interaction with the health providers? Is that something
Let me just start off by saying the nurse manager on that floor has her door open most of the time, and invites us to drop in and just check in with her. She knows when we're there. Don't the nurses come and remind you who might need a visit? Somebody tell about that.
I have I was on the ACE unit last week, and I checked with the manager, and I can't remember her name.
Devin Cockrell.
Devin, and she said, well, if we check with her, and she tells us what she needs us to do. Sometimes we may take a patient, they may be bringing a patient out into the living room, and it might be necessary for us to sit there while they in the living room, maybe.
They actually need you to be there,
just kind of
to keep that patient company.
Yes.
So you do have interactions. What about with the nurses who are in charge of the patients you work with?
We can go to the nurses at any time if the patient needs anything.
And yes, and get permission.
Yeah.
And do you ever go to the nurse and ask?
Yeah. Yes.
You do that, don't you?
If they want to do something, if they want something to eat or want a cup of coffee or something, then it's important for us to ask the nurse if she
you have to do that first.
Is able to do that.
But the reports we get
ask for things that they're not supposed to have.
I didn't realize I knew so many nurses until something. When I came up, I was a patient myself here like a couple of weeks ago.
Right after the hurricane.
Yes.
Yeah.
And they all come in to see me. I mean, they knew me and they come in to see me. And I knew them and I passed them in the hallway, but I really didn't know that they paid any attention to me.
Yeah, they do.
They do.
Yes.
Because we haven't been coming up here. I was in the grocery store, which is where, since Hurricane Ike, you find out who's still in Galveston. And one of the nurses came back and said, "When are you coming back up with Misha?" And I wouldn't ask her who she was. I was waiting to get back up there so I could see her picture on the wall. Only the pictures are gone. But we get a lot of interaction with them because if we ask, if the patient asks for something, we are not equipped to do that. But then there's also the staff seems to, telling us I played the piano, a lot of times they will come and tell me they particularly like what I played and thank you. And I've had occasions where family members have come out and they said, "Would you come in and speak to my sister? She's my mother," or so and so, and then and so I have run into, because with my age, I think I'm the oldest one up here. Yes, I am. But anyway, I have had, I can relate to the patients. I've been up there a couple of times too myself, and when I found I had to go in the hospital, please let me go up to the ACU because I know the people up there. But there, I've had a case where one woman that I knew vaguely from another organization saw me pass by her room on the way to the piano, and she was busy, and I didn't go in there, but then she indicated she wanted me to come there.
She sent for you, didn't she?
And yes. And when I got in there, it was somebody that she needed to tell me all the things I had not known about her and her family and the relationship and all that. And I have seen her twice since then, and she's promised to keep in touch with her and everything. But then there was another case where a member of my denomination, a young woman that I did not know, but her father was in there, and he passed while I was playing, and she said, "Thank you." She said that's his favorite song when he played it.
Oh. You were playing her daddy's favorite song when he died. And
he had it. So I'm basically doing, because what I'm doing basically is the hymns and things that I remember. Since my vision is deteriorated, I can't read the music too well anymore, so I'm doing it. But as I'm playing, I'm mentally singing things myself, and it seems to relate to a lot of things.
Yeah. But when you talk the way you do about with such joy, what you just do so well, it makes me think of the age-old expression, "We just keep on keeping on." Mm-hmm. And I think that whole sense of being a community of caregivers, being part of the team, since the day one we've been made to feel a part of the team, the interdisciplinary team, and that has given us lots of encouragement and support. And we were reduced to no floor at all, and many of you across the country may not know that about what the hurricane did to us in terms of returning, but we've this little group of volunteers were standing ready the day the unit opened again, because we were getting pretty exhausted waiting for things to be more normal. So it's great to have this ability to communicate what we're doing.
We're about to run out of time, and it's always great to have kind of the take-home message, or what is there something that any of the panel members want to say to kind of to wrap up in a way the importance of what they do, and any message for a health provider.
Come out and visit.
Care for an older patient. So what would you tell them?
Come out and visit with us. Come to visit.
So the health providers go to the ACE unit?
Yes.
As well?
Come up to the ACE unit. See what we do. We
That
could
is
use
a
the
wonderful
help.
idea.
And we need someone that can speak the Spanish language.
Yeah, we've had
there's many times I
translators.
can't communicate with them because I don't understand it, and we really could use some volunteers that speak the language.
That's a big hindrance when you don't speak their language, or
I'd
they
love
don't
to speak it, but I can't.
They
I can
speak ours.
understand Yugoslavian, but I can't understand Spanish.
I think too that we have a lot of foreign doctors in our area. I don't know about the other areas.
Oh, yeah.
And I
They're
think
all
that
over.
sometimes the patients have a hard time understanding what the doctors are telling them to do. And I think it really is important that the doctors have someone with them that can help patients to understand what the foreigners, what they say, because especially being older, because you just can't understand what some of the doctors say to you.
So are you suggesting, Olive, that any physician who has English as a second language,
yes,
whose primary language is their own native tongue, that any of us, could we say that any of us would be available to journey with them,
yes,
and stand someplace in the room nearby to help communicate?
Right.
That's a great idea, Olive. I don't think that, see, coming from you makes it authentic. It's not something that somebody dreamed up, but I think that would be incredibly helpful. I've heard so many of you over these last 5 years talk about how many people you know. You not only connect because you've recognized somebody, or you're the same age. You connect because you're the same age, or in the elder years, but you actually know them and know a lot about their history, and could be a very productive other in the communication world, because we are very international, and we pride ourselves in that. That's a grand idea. And
an added benefit.
Yeah, it could add a great benefit. One thing you asked a moment ago about education. Once a month we have a continuing education session. We meet over at the William Temple Center because parking is easy, it's very accessible. And we have invited so many physicians, therapists. We've had an occupational therapist, a physical therapist. We've had doctors. We've had research people. Glenn Auster, who's going to be speaking at our lecture. Yeah, what's the name of the lecture?
Series on Aging.
Yeah, the Series on Aging lecture next Tuesday night. Glenn talks about favorable emotions. What good are good emotions? What do they do for us? And he gave us an in-service training just last week. So we have really top-notch providers giving us a heads up and giving us a good presentation on things we need to know, which helps us grow together as a community and gives us a common base of knowledge.
Well, I really like to thank the panel for being here and taking the time. It's really valuable to hear from them.
So proud
of healthcare and what you do with the ACU. And Helen, thank you for bringing them together, Marilyn. Work with them as well. So we got to wrap this up. Is there anything else? Again, you're welcome to join with us, and maybe we'll get up to the ACU and visit with you.
You got to go.
You go.
Thank you for coming.